Hello, my name is Dr. Heidi Yount, and I'm here today to talk to you about strategies to implement changes in practice for HPV vaccination. Today's objectives are to identify barriers for vaccination, to practice overcoming the barriers to increase HPV vaccination, and to identify educational resources. My disclosures. I have nothing to disclose. However, this presentation does mention Gardasil 9, as that is the only HPV vaccination currently available in the US. However, I have no affiliation with Merck. So what are vaccination barriers? As you can see them listed below, they include side effects, low perceived risk of contracting the disease, low awareness of availability, limited recommendations by physicians or mixed messages, limited access, inadequate coverage, failure to attend well visits, and lack of adequate reminder systems. So we're going to talk through each of those one by one. Most important when we are talking about vaccines is to be aware of the side effects. HPV vaccine does have a few serious side effects. You can see them listed below. They include hypersensitivity reaction, anaphylactoid reaction, and anaphylaxis. All of these are very rare. One thing to note is an allergy to yeast as a severe reaction would be a contraindication. Your most common side effects that we will see in discussing this vaccine with the patients are the common side effects. These are injection site reaction. 89% of patients will experience pain, 48% will experience swelling, and 34% will experience redness. 11% will experience headache, and patients also experience syncope. This is why we would want to observe for 15 minutes after administration. All of this data is taken from the package insert for Gardasil 9. Next, we have low perceived risk of contracting the disease. The problems with this is parents do not feel like young teens are at risk. And couples that are in monogamous relationships aren't necessarily worried about exposure. Your scenario here, the future is uncertain. However, HPV vaccination offers protection. Next, we have low awareness availability. So this is just patients not realizing that, one, a vaccine is available, or two, that they would be eligible for it. So we get around this by providing vaccine information in waiting rooms or exam rooms. We discuss vaccines at every visit to make sure that patients know what they are due for and how to access them if they're not available in the office. And then utilizing reminder systems to identify patients who are due for vaccines and have not presented for an appointment. Next, we have limited recommendations by medical staff. The issues here is that physicians are not necessarily having the time or education to give a recommendation. When we're having a discussion with a family, the vaccine discussion might stop with no, and then not going into asking why the patient or family does not want the vaccine. The next issue is not giving equal weight to the HPV vaccine along with Tdap and meningitis for our teenagers. And then just not having staff recommend HPV vaccination with confidence. We need to improve our shortcomings. The next would be missed vaccine discussions. So this would be patients that are presenting for a visit that's not a preventative visit, and we have not queried to see if they are due for any vaccines. Next, we have staff not encouraging vaccines, or if they are preparing the patient during a well child, they're only mentioning the required vaccines that they would have to go on in school, not mentioning all of the vaccines that they would be eligible for. And then finally, making sure to review updates about the changes to a vaccine schedule at department meetings so that not only you, but everyone that you work with is up to date on the current recommendations. The next issue is inadequate coverage or limited access. Ways to work around this are identifying providers that have VFC, the vaccines for children providers available through the state, using your local health department, working with the school on vaccine initiatives, considering mobile vaccine units if you're in an area that has a lot of transportation issues, and considering clinics outside the regular office hours with an ability to walk in without an appointment. Because if you are able to just decide that you want to proceed with a vaccine and go get it when you've made that decision, you're much more likely to complete that vaccine. The next issue is failure to attend well visits. How we get around this is to use an EMR or your registry to identify vaccine eligible patients. So an example of this would be to identify your 11 and 12-year-old patients within your system and send them correspondence via mail, an email, a text message to encourage scheduling a well visit, because they might not have realized that they were due for one. And then in case that patients don't attend well visits, making sure that we review vaccines on every patient at every visit. And this can either be by the physician looking at their record, or the nurse medical assistant helping as well. Even if you're not planning to give an immunization at that visit because they would be sick, for example, at least then you can identify that they are due. The other issue is that students might be completing a sports physical at an urgent care or a chiropractor office and not even being offered vaccines. So if we're not seeing these patients in our office, we're not having the opportunity to have that discussion. Next is lack of adequate reminder systems. So this is how we can use our electronic medical record alerts and settings to make sure that we are able to complete the dosage series and bring the patients in for appointments. It's very important, especially if you give a first HPV vaccine dose at an office visit, that they schedule the second dose before they leave the office, and then they will get a reminder message. I do oftentimes set a chart alert as well in case that they no-show, so that then we can follow back up with that family. And then you also can use the Ohio Impaxis system, our immunization registry, to run reports and find out what patients in your practice are due for vaccines. Okay, so in real life, how are we going to get this done during a busy office day? So workflow. Nursing staff reviews the vaccines as part of rooming the patient or in their pre-visit planning. A lot of times what our practice does is the nurses will pull the Ohio Impaxis the day before visits so that we can be prepared to go the day of. And then if we have an add-on child or whatever, we can pull that as we need it. We also will use standing orders so that the vaccine can be given without an individual physician order. The most important thing for us as physicians is be prepared for the questions and hesitations. What you want to do is use motivational interviewing techniques. Do not stop at no without a discussion. Consider talking directly to the adolescent about vaccines, or even consider having that vaccine discussion as part of the confidential part of the teen visits. We have seen in our practice that even if the parents decline, the adolescent has been educated and can make an informed decision, even if it is once they turn 18, if they decide that they want to proceed with vaccines. And then have educational resources readily available. This could include videos on a practice website, a poster on an exam room wall, handouts that you have available, anything that you can easily talk through with the families and patients and use examples. So what is motivational interviewing? There are 4 components to it. The first is to ask permission to have the discussion on whatever topic that you are doing. Then you want to ask the family and patient open-ended questions about their objections. You want to express empathy and engage in reflective listening. And then finally, you want to summarize both what your patient or family has said and what recommendations that you have made. So now we're going to go through some common HPV questions and concerns that parents oftentimes will ask. So the first question is, giving the HPV vaccine to my 11-year-old will give them permission to be sexually active at a younger age. You can reassure your patient and families that this was false. This was reviewed in a 2016 systemic review. that showed no earlier incidents of sexual activity related outcomes. They were looking at STD testing, pregnancy, contraceptive counseling. So that is indeed false. The next question, why at age 11? Why not wait until they are older? The younger that the HPV vaccine is given, the better immune response that the child will have. You are also much more likely to have completed the vaccine coverage before exposure and onset of sexual activity. You have fewer doses if you're able to do 2 doses rather than 3. That generally is meaningful for our young patients if they don't have to have one more shot. And then possibly cheaper. If you have a patient and family that is eligible for the vaccines for children, the vaccine is essentially free. Next question, my kid is a good kid. They will never engage in high-risk behavior. That's nice. We do all hope for that. However, the CDC estimates that there are currently 79 million Americans infected with HPV and 14 million new cases every year. With those numbers, nearly everyone will be exposed to HPV at some point in their life. And even if your child is the best kid, low risk, not engaging in any high risk behavior, their partner or partners may have had a history of high risk behavior. The next question I get, the vaccine is new. It is not. It was licensed in 2006. It's just for girls. That is also false. The recommendation to give HPV vaccine to both boys and girls was given in 2011. Boys can also get HPV-related cancers, including penile, anal, rectal, oropharyngeal cancers, and can transmit HPV to their partners. Then the vaccine must cause infertility. Multiple studies have shown no increased rates of premature ovarian insufficiency in the vaccinated versus non-vaccinated population. However, HPV and the procedures needed to treat it, including LEAPs, for example, can certainly affect pregnancy outcomes. So if it's not going to make us infertile, then certainly it must cause other illnesses, right? They have looked at POTS, chronic fatigue syndrome, complex regional pain syndrome, and the autoimmune diseases, and have not been able to find any correlation between HPV vaccination and any of those syndromes. Okay, now we're going to go through some cases, and these actually are cases from my practice. The information, patient identifiers, has been removed so that there aren't any HIPAA concerns, but these are real life examples. So my first case, 2 sisters, ages 11 and 14, presented to their office with their dad. One was for her scheduled well child visit, the other was just for vaccines. The 11-year-old is the nurse visit for vaccines, and the dad, before I enter the room, tells the nurses to give just the required vaccines for school. The 14-year-old is being seen for her well child visit. She has not had the HPV vaccination, but she is otherwise up to date. So what are our next steps in going into the room to see these patients? So this is where our motivational interviewing is going to come in. We need to ask permission for discussion. And in this case, consider talking to the teens alone. We need to express empathy and use reflective listening. We need to ask open-ended questions. As we're having the conversation on the vaccines, I asked the dad for his reason for referral. I had a vague answer that he had done his research. He did not elaborate further. The girls, when I asked them questions, did not want to talk or respond to me either. So to summarize, this dad in particular was not overly open to discussion, nor were the children. So I reaffirmed to them that HPV vaccine was for the prevention of HPV-related cancers and genital warts. And finally, in my discussion, I did get dad to agree to take the patient handouts that I had so that at least he could do more research from approved scientific sources rather than the internet or wherever else he had done his research. They agreed to review the resources, and I will review vaccination with them again at the next visit. Case 2, An 11-year-old female who's the youngest of 3 daughters presents for her well child visit. She is still in 6th grade, so her mom was not planning for vaccines at this visit, nor was the patient. Due to her age, her vaccines were discussed, and mom mentioned that she was planning to wait until the summer before she starts 7th grade. I offered HPV vaccine to her at her current visit, which was in the fall, and then just honestly to make it simpler, that then she could do her 2nd dose with her DTaP and meningitis in the summer. When this discussion ensued, then mom told me that she had become unsure about the HPV vaccine after reading more after her older daughters were vaccinated. This really caught me off guard because this mom is a nurse at our local hospital. So what did I do? So I asked permission for discussion. I again used expression of empathy, reflective listening. As I began to ask the patient and family open-ended questions, I did ask the mom, what specifically had she read about that she was concerned? Where could I help her to answer her questions, get some more information? She was unable to give me any specific example. And then when I tried to ask the daughter what she thought about the plan, she was just generally adamant that she was not getting any vaccines at this visit. So as the mother and I talked some more, I did review with the mom that the older siblings had gotten vaccinated, had not had any issues. Obviously her daughter was not mentally prepared for vaccines at this current visit. Mom was in agreement that they would proceed with HPV vaccination at a further visit. And then I did review that this is a cancer preventing vaccine. So finally, in this particular instance, we did not give a vaccine at this visit. I did encourage them to schedule her first dose soon, just so that she could complete her series when she does her other vaccines prior to her starting 7th grade next fall. My third pediatric case, I had 2 siblings that presented for their well child visits, ages 11 and 9. The 11-year-old is a male who actually would be starting his HPV series at this visit. Mom did not have any questions. She, wants the children to get vaccinated. So in effort of simplicity, I offered to mom that both children actually are vaccine eligible to do the HPV at this visit. Mom thought that was a great idea to simplify a nurse visit in the future. So we were able to do both children at that visit. So overall, my teen recap of improving HPV vaccination. We want to review vaccines at all visits because you might not see them for a preventative visit. You want to use your electronic medical record to identify eligible teens to come in for an appointment. You want to use equal language when referring to the 7th grade vaccines. You do not want to use your child is due for DTaP, meningitis, and if you want HPV, you need to use your child is due for DTaP, meningitis, and HPV as a complete sentence. And then by all means, you can stop, you can ask for questions, but presenting them all on the same level will definitely get us further in improving vaccine completion rates. Be prepared to discuss the vaccines with the patient and parents. Because if you seem uncomfortable and unsure about the vaccine, then that's not going to give any confidence to the patient parent that you actually want them to get it. Be prepared to provide education and offer to bring them back for a later appointment if they're not ready, for the vaccine at that office visit, or maybe they're with one of the parents and they need to talk to the other parent. That's fine. But make sure that you ask again the next time you see them, even if it is, a week or two later, that would, if you are persistent, then at least it has the families realizing that, this is important to you and you are trying to get it done. And then finally, emphasize that this is a cancer reducing and preventing vaccine. There is not any other vaccines that we have on the market that is able to reduce or prevent cancer. And that is very meaningful to our patients. As an example, using the tools that I just talked about with the teenagers, we just recently met with our local health department. We do this once a year, and they review our overall immunization rates. With all of the things that I talked about within the last year in our practice, we were able to improve our completion rates by 7% and also had a 7% reduction in missed opportunities. So we definitely are moving forward. Obviously there is still work to be done, but this can make valid changes by employing all of the options that I just discussed. So what educational resources do we have available? I've listed several out here on the slide. The CDC, Children's Hospital of Philadelphia, the Ohio Academy of Pediatrics, and the Ohio Department of Health really have very nice vaccine videos, handouts, handouts specific to different communities, if that is a community in which you work out or work with. The Ohio Department of Health, if you really have patients that are questioning you on, what Ohio cervical cancer rates look like, they have all of the stats available from 2022. So all of these things are available, and several of the handouts you would be able to link to your practice website. You can load the videos onto your website and just have it very easy for the parents to access and review. Another resource that I found very helpful is a book by a fellow family physician called Let's Talk Vaccines by Gretchen LaSalle. Gretchen actually breaks down all of the different vaccines, but provides vaccine-specific resources, topics for discussion in her book. It definitely is a good read. All right, so finishing up the teenagers, what about the adults? So we need to consider catch-up vaccination in our patients from ages 18 to 26, and then consider shared decision-making for patients ages 27 to 45. The most important piece with this is to know where to refer adults who want vaccines. Most offices, including my office, does not have HPV vaccination for adults. We are trying to work on that, but it's not available currently. So you need to know, do your local pharmacies stock adult HPV or the Gardasil vaccine? Your local health department should. They are able to give it to anybody that is age eligible for it. But also knowing what hours your health department is open for vaccines, how the patient needs to access it, if there are phone numbers, all of that can be very useful, especially if we don't have vaccines in the office. So when do we have these HPV vaccination conversations with our older adults? The most common place would be at well woman visits or contraceptive counseling visits, when obviously you're talking about women's health topics. Your next scenario would be if a patient's presenting for colposcopy or if they have a history of an abnormal pap smear. Again, seeing if they are age eligible, were they vaccinated, should they proceed with vaccination now? And then the other scenario is we're seeing an increase in patients with HPV related head and neck cancers. That is another good opportunity to have discussions with, maybe those patients or their family members that, perhaps, with vaccination that this could have been prevented. So obviously, depending on your age of the patient, if they're vaccine eligible or not, that would kind of guide how you're having these conversations. But I feel like in a lot of our adult conversations, even if the patient themselves is not necessarily vaccine eligible, many of them have not thought about it for their children or even grandchildren. All right, so now we're going to go through a couple of adult cases. My first case is a 43-year-old female presenting for her annual wellness visit. She does have a history of cervical cancer diagnosed about 5 years ago. Prior to her diagnosis, she had a low-grade PAP during her pregnancy. Unfortunately, she had a preterm birth. She got lost to follow-up after delivering her son. And I didn't actually see her again until after her cervical cancer was diagnosed. Her son is currently 8. So what did we discuss with her? First, she was never vaccinated for HPV. She is still age eligible, but will she have benefit? The data is not terribly clear in this instance. Her oncologist has not encouraged her that she would need the vaccine, but she still could benefit from it if she wanted to pursue it. In her particular visit, the day that we had this discussion, the most important point I was able to make for her was that her son will soon be age eligible, and she was completely unaware that HPV vaccination was available for boys. So I made sure to reiterate that, when he becomes eligible, that he can be vaccinated against HPV, and hopefully he will be able to not have an HPV related cancer himself, and hopefully not to transmit an HPV related cancer to a future partner. My second adult case is a 47-year-old female who presented for cervical cancer screening after many years without screening. And it was approximately a 6 or 8 month process for me to get her to schedule a PAP once we had the discussion about it. So when I did her pap smear, I did HPV co-testing as is recommended for her age group. She is positive for HPV 16 on her pap. Colposcopy is recommended and was completed, and she has a high-grade CIN3 lesion. She has now been referred for further treatment. So what did we discuss with her? And this was actually a discussion that I had with her when I did her colposcopy. When at that point we knew that she just had HPV 16. So she was never vaccinated, and she has aged out of the recommended age group. So vaccinating her is not really an option. She does, however, have custody of her 2 young granddaughters. So we discussed vaccination for them when they become age eligible, because especially in her case, she has an HPV 16 abnormality at this time that would be taken care of by the vaccine. So in summary, use all available appointments as an opportunity to discuss vaccines, partially because you never know when you will see any of these patients again. You need to educate the staff to be knowledgeable and supportive of vaccines. You need to present HPV vaccination equally to DTaP and meningitis, not as an optional vaccine. We need to offer vaccines outside of regular office hours or office locations. And this can include Saturday mornings, weekday evenings, school-based vaccinations. Again, a mobile vaccine unit that could go to a church, for example. And finally, we need to talk about HPV. None of these HPV related cancers are good. And it doesn't matter if you have a cervical cancer or you have a head and neck cancer. We don't want our patients to suffer because we were uncomfortable talking about the subject and didn't pursue further when the families didn't think that it was important. And finally, we have to be vaccine champions. If we are not vaccine champions and don't do the work to get our patients vaccinated, they're not going to get it done. So I will leave everybody with that. Thank you.